Psychological therapy. Okay, we are still here reading from the Crash Course Psychiatry book. And we are still here in part one and section one of this book about general things. We've talked about psychiatric assessment, and then we've went quickly through biological therapies. I mean psychotherapy, psychopharmacology, and electroconvulsive therapy. And in this material, we will talk about psychological therapy. Psychological therapy describes the interaction between a therapist and a client that aims to impart beneficial change in the client's thoughts, feelings, and behaviors. Psychological therapy, which is often known as psychotherapy or talking therapy. So it's the same thing: psychotherapy, psychological therapy, or talk therapy, or talking therapy, may be useful in alleviating specific symptoms, for example, social phobia, or in helping a client improve their overall sense of well-being. Members of different professional disciplines, including clinical psychologists, psychiatrists, occupational therapists, mental health nurses, art and drama therapists, and counselors, may all practice psychotherapy, provided they have had adequate training and supervision. So let's talk about some approaches in psychotherapy. Psychotherapeutic approaches. There are many different approaches to psychotherapy. Research has shown efficacy for many different types of psychotherapy, for many conditions. This has led to the idea that the success of psychotherapy might be due to certain common therapeutic factors, as opposed to specific theories or techniques. A comprehensive review of psychotherapy research showed that common factors occurring in many models of therapy, occurring in any model of therapy, these factors account for 85% of the therapeutic effects, whereas theoretical orientation only accounts for 15%. Therefore, the use of a modality with which the patient can identify and work may be more important than the theoretical basis of the therapy itself. Common therapeutic factors, including client factors, personal strength, social support, and now, of course, therapist-client relationship factors like empathy, acceptance, and warmth, in addition to the client's expectancy of change. So these are the common therapeutic factors. We have client factors, we have therapist-client relationship factors, and of course we have the client's expectancy of change. Here we have some hints and tips. Self-help is the umbrella term used to describe the process of self-guided improvement. Often, self-help resources utilize psychological techniques, especially cognitive behavioral therapy, and educational materials. Self-help may involve books, DVDs, interactive websites, and discussion groups, including internet-based forums. Self-help materials may be provided from and progress followed and reviewed by healthcare professionals. This self-help would be known as facilitated or guided self-help, and can be incredibly useful for some people, either in the management of less severe psychological difficulties or as an adjunctive to other forms of treatment. So we have self-help, we have facilitated or guided self-help, and we have group-based peer support. Group-based peer support is a form of self-help delivered to groups of patients with shared symptoms, during which experiences can be shared and progress reviewed by a facilitator. Another hints and tips. The single factor most commonly associated with a good therapeutic outcome is the strength of the client-therapist relationship. We call it therapeutic alliance, regardless of the modality of therapy. In some cases, it may be beneficial to use a mixture of modalities like psychodynamic, interpersonal, and cognitive behavioral therapy. Uniquely tailored to, and this use of, the mixture of modalities that uniquely tailored to understanding and treating the patient, known as eclectic therapy. Eclectic therapy. So let's talk about counseling and supportive psychotherapy. Psychotherapy is sometimes distinguished from counseling, although they exist on a continuum from counseling and supportive psychotherapy, least complex, to psychodynamic psychotherapy and sophisticated cognitive therapy, more complex and requiring more specialist training. Counseling is usually brief in duration and is recommended for patients with minor mental health or interpersonal difficulties. So this is counseling. Or for those who experience stressful life circumstances like grief counseling or bereavement. Counseling helps patients utilize their own strengths, with the therapist being reflective and empathic. The provision of relevant information and advice, which is undertaken by healthcare professionals for all specialties, is also considered to be counseling. In person-centered counseling, the therapist assumes an empathic and reflective role, allowing patients to discover their own insights using the basic principles that the client ultimately knows best. We have something called problem-solving counseling, is more directive and focused, as patients are actively assessed in finding solutions to their problems. These types of counseling may provide some benefit for patients with mild anxiety and depression. However, they tend not to be as useful for more severe mental disorders. Okay. So that's about counseling and supportive psychotherapy. What about psychodynamic psychotherapy? Psychoanalysis and psychodynamic therapy have changed substantially since Sigmund Freud introduced psychoanalytic theory in the late 19th century. Here we have a figure that summarizes some of his ideas regarding personality. This is the iceberg metaphor that summarizes Freud's ideas about personality. So the iceberg itself here represents the structural model of the mind. And the sea levels here, and the sea, of course, represents the topographical model. We have two models Freud was talking about. The structural model about the structures and the components of the mind, and here the levels of the mind. So the iceberg represents the mind. We have three parts, which is within the structural model, we will call it, with structural model of the mind, okay? We have id, ego, and superego. Id, ego, and superego. And we have, within the topographical model, we have three levels. Conscious, which is outside the sea, pre-conscious, and unconscious. And you can see that the iceberg, part of the iceberg is within the conscious part, and part of the iceberg, and actually most of it would be emerged within the unconscious state, I would say. And in between we have the pre-conscious. So let's start with the structures. We have the id, which is the pleasurable. It's the part that's governed by pleasure principle. demands immediate satisfaction, primitive, instinctive, animalistic, and hedonistic. This is the id. We have the basic instincts in it. We have the super ego, and you can see that most of the id is within the unconscious. Within the unconscious. What about the superego, the ideal? It is the ethical and moral part that sets rigid standards for behavior, usually internalized from the parent's moral code, and gives rise to feelings of guilt, and is often referred to as conscience. Okay. What about the ego? What about the ego? The ego, or the actual, this is the part that is in touch with reality, that mediates between the demands of id and the superego, and of course with external reality. And most of it is within the conscious and the preconscious mind. So that's it in general. The contributions of many other influential theorists like Millen Klein, Carl Jung, Alfred Adler, John Bowlby, Donald Winnicott, alongside the introduction of evidence-based practice, has meant the continued evolution of theory and techniques. However, the basic assumptions of psychoanalytic theory remain consistent, namely that it is mainly unconscious thoughts, feelings, and fantasies that give rise to distressing symptoms. This is the first assumption. Okay? And that these processes are kept unconscious by defense mechanisms, which are employed when anxiety-producing aspects of the self threaten to break through to the conscious mind. So that potentiate giving rise to intolerable feelings. That's where defense mechanisms rise. Anyway, and here we have a table that give some examples of defense mechanisms. We have more than one type of defense mechanisms. We have pathological defenses, immature, neurotic, and mature defenses. To talk about these one by one, we have some examples actually. So let's okay, we can go quickly through them. We have denial. Denial is one of the pathological defense mechanisms. It means that what's denial? It's the failure to acknowledge the existence of an aspect of reality that is obvious to others. That's denial, as simple as that. Here we have an example. A man who was badly assaulted reports that it did not happen. And he's not lying. He is not aware that it happened. So it's again, these defense mechanisms are unconscious mechanisms. The person is not aware that he's doing this. Projection, it is the attribution of unconscious feelings to others. For example, a man who strongly dislikes his neighbor states that his neighbor hates him. So he projects his feelings. Splitting is a rigid separation of two extremes, like a woman is convinced that her boss is an evil man after she was disciplined at work. We have some immature defenses like fantasy and somatization. Fantasy means fantasy is use of imagination to avoid acknowledging a difficult or distressing reality. We have an example here. A schoolboy thinks about killing a bully rather than taking action to stop the bullying. Somatization, another immature defense, the transformation of negative feelings toward others into physical symptoms, like a man stuck in an unhappy marriage develops medically unexplained back pain. Neurotic defense mechanisms like repression. Repression is blocking painful memories from consciousness. Like an adult child who has no memory of being beaten by a beloved parent. Reaction formation, the switching of unacceptable impulses into opposites, like a man who hates his job, works extra hard, and performs incredibly well. Intellectualization is concentrating on intellectual aspects to avoid emotional aspects of a difficult situation. Like a woman diagnosed with terminal cancer develops an intense interest in the classification process of tumor staging. What about mature defense mechanisms? We have humor. Humor is using comedy to avoid provoking discomfort in self and others. Like a woman laughs and mocks herself after arriving at a formal dinner dressed in casual clothes. Sublimation is redirecting energy from unacceptable impulses into socially acceptable activities, like an angry man vigorously works out at the gym. Suppression, this is the only conscious defense mechanism, I would say. So it is consciously avoiding talking about disrupting problems. Like a student cleans the kitchen while waiting on exam results. So these are some examples actually. Not all defense mechanisms are mentioned here. So the essential aim, let's get back to psychoanalysis and psychodynamic therapy. The essential aim of psychoanalysis or psychodynamic psychotherapy is to facilitate conscious recognition of symptom-causing unconscious processes. Recognition of unconscious processes that causing the symptoms. It is the therapist's role to identify and interrupt these processes. So, of which patients are unaware, of course. Another role for the therapist is to facilitate their understanding of unconscious processes in the context of a safe, caring relationship. Historically, various methods have been used, like free association, hypnosis, interpretation of dreams, and fantasy materials. Analysis of defense mechanisms, and we have here in the table we've talked about defense mechanisms, for example. Okay. However, modern psychodynamic psychotherapy mainly relies on the analysis of transference and countertransference. Transference is the theoretical process by which the patient inappropriately and, of course, unconsciously transfers feelings or attitudes experienced in an earlier significant relationship onto the therapist. For example, a man patient becomes angry with his therapist, whom he sees as cold and uncaring. So unconsciously, that therapist reminding him of his mother. This is transference. What about countertransference? Countertransference refers to the feelings that are evoked in the therapist. So countertransference about the therapist. So countertransference refers to the feelings that are evoked in the therapist during the course of therapy. The therapist pays attention to these feelings as they may be representative of what the patient is feeling, and so help the therapist to empathize with the patient. Often, therapists have undergone therapy themselves as part of their training. This helps them to separate out what feelings belong to them and what feelings belong to the patient. Okay, let's continue. What's the difference between psychoanalysis and psychodynamic psychotherapy? Although the terms psychoanalytic and psychodynamic are often used interchangeably, they differ in the following ways. Psychoanalysis describes the therapy where clients see their analyst several times per week for a non-specific period of time. Psychoanalysis is conducted with clients lying on a couch, with the analyst sitting behind them out of view. The analyst may be quieter than in psychodynamic therapy, and there is space for the patient to explore what comes into their mind and for the analyst to help the client understand how they relate to the therapist. This is the transference, and to others. While psychodynamic psychotherapy is based on psychoanalytic theory, yes, however, it tends to be more interactive and occurs once weekly for 50 minutes per session, during which time the patient and therapist sit face to face, and the duration of therapy varies depending on the patient's individual needs, but it can range from a few months to several years. Psychodynamic psychotherapy may be conducted on an individual basis or in a group setting. Due to time and resource-intensive nature of both the health service and the patient, of course, of classical psychoanalysis, this is very seldom offered within the national health system. Here we are talking about UK, but with weekly psychodynamic therapy being favored. However, psychoanalysis is still practiced within the private sector. Mentalization-based therapy is one example of therapy derived from psychodynamic psychotherapy and is summarized in the table that we will see it later on, inshallah. Here we have some hints and tips. Attachment refers to the bond between an infant and their primary caregiver. So attachment is one of the basic and one of the most important aspects of some psychoanalytic theories. So that's why we are talking about them here. Attachment refers to the bond between an infant and their primary caregiver. How a person was treated by their primary caregiver during their early years sets the tone for that person's expectations of the rest of their life, how others are likely to behave toward them, and how they should behave in return. So, disrupted attachment during early childhood often contributes to problems with mood, anxiety, and self-esteem in adulthood. And attachment difficulties often emerge during psychological treatment, consciously or unconsciously. Here we have a communication tip. Transference and countertransference are unconscious processes that often occur in sitting outside psychodynamic psychotherapy. Patients may inappropriately react to healthcare professionals as if they were some significant figure from the past. An example is when patients express unwarranted anger toward doctors or nurses when they do not receive immediate attention. This may be considered anger that was initially experienced toward neglectful parents. Similarly, health workers may misplace feelings from their own earlier relationships onto patients. Okay. Here we have, this is just quickly about psychodynamic psychotherapy. Now, let's talk about behavioral therapy. Behavior therapy is concerned with changing maladaptive behavior patterns that have arisen through learnings, either classical or operant conditioning. So that's it. The premise is that if a patient changes his or her behavior to make it more adaptive, this will have positive effects on how they think about things. Here we have a table that summarizes some of techniques that's used in behavioral therapy. So it's about just, modify your behavior. Here we have some techniques: exposure with response prevention, relaxation, modeling, activity scheduling, and target setting. About exposure, we use exposure in phobias and avoidance, in post-traumatic stress disorder, and so on. What's exposure? We have a graded exposure. Graded exposure, in graded exposure, a hierarchy of increasingly threatening situations is created. For example, spider in another room, spider in the same room, spider near the patient, spider on the patient's hand. So you see that the hierarchy is is ordered from the easier to the most difficult. So patient exposed to, or imagines, according to the case, exposed to the least threatening situation and stays in the situation until their anxiety reduces toward normal levels. When anxiety relief has been achieved, the patient are then exposed to increasingly threatening situations. Flooding is another form of exposure, when patient instantly exposed to the highest level of their anxiety hierarchy until their anxiety diminishes. For example, throwing a patient with fear of water in a deep end of a swimming pool. Flooding by imagination is termed as implosion therapy. So implosion therapy is flooding by imagination. Another behavioral technique is called exposure with response prevention. We use this kind of treatment or this technique in obsessive compulsive disorder. Patients are encouraged to resist carrying out compulsions until the urge diminishes. So they are then exposed to more severe compulsion evoking situation. So we expose patients to compulsion evoking situations while we prevent them from doing any compulsions. Another behavioral techniques, relaxation would be part of them. We use it in anxiety. Like we have many kinds of these: progressive relaxation of muscle groups, breathing exercises, visualizing relaxing images and situations. So this is called guided imagery when it's imaginations. Okay. Modeling, we use modeling in phobias and avoidance. When patients observe the therapist being exposed to the phobic stimulus, then attempts the same. So, yes, modeling. Another behavioral technique, activity scheduling and target setting. We use that in depression. So patients are encouraged to structure their day with certain activities, as reduced activity can lead to further lowering of mood due to reduced stimulation and few opportunities for positive experiences. So these are some techniques. Communication. Avoidance increases anxiety. Many of the behavioral techniques used to treat anxiety disorders involve systematic exposure to anxiety-inducing thoughts or situations. Supporting the patient to realize that they can tolerate and in due course reduce their fear. It can be helpful to explain to patients that they will have to experience some anxiety in order to overcome it. So at the beginning you would have more anxiety. So, what about cognitive behavioral therapy? Cognitive behavioral therapy is based on the assumption that the way in which individuals think about things, like we are talking about cognitions, subsequently determines how they feel and behave. So that's the basic assumption here. So the way in which individuals think about things subsequently determines how they feel and behave. Likewise, physical or physiological feelings can influence the way in which an individual thinks and behaves. This is another thing. So we have something called automatic thoughts. Automatic thoughts involuntarily enters the individual's mind in response to a specific situation. For example, he doesn't like me, I'm such an idiot, or I'm so boring. We have dysfunctional assumptions. Dysfunctional assumptions are the faulty rules that individuals live by that underlie that automatic thoughts, underlie what automatic thoughts occur. Okay? When these rules are broken, as they inevitably are, the result is normally psychological distress. For example, if I don't come first, then I'm completely useless. Again, If I don't come first, then I'm completely useless. This is an assumption that would emerge, automatic thoughts when there's something wrong. So, another assumption: if I hurt someone, then I'm evil. The rules themselves may be inherently problematic. For example, if I tell people how I feel, this means I'm weak. If I tell people how I feel, this means I'm weak. The patient is often encouraged to keep a diary of automatic thoughts, and from this, the patient's thinking style can be identified. Technically called cognitive distortions. We look for those. Here we have some examples of cognitive distortions in the next table. These are some examples. We have all or none thinking. This is the first cognitive distortion. It means that when you evaluate something, evaluating experiencing using extremes such as amazing or awful, so all or nothing. For example, if I don't get this job, I will never work again. All or none. Mind reading. It's assuming a negative response without relevant evidence. For example, because she didn't reply to my text message, she hates me. Okay. Personalization, which is blaming self for an event. It's all my fault that the relationship ended. Personalize everything, Overgeneralization, drawing negative conclusions on the basis of one event. Because I spelled a word wrong in my essay, I will get a lower grade. Generalization, okay. Fortune telling, which is assuming knowledge of the future. For example, now I've been told of by my boss, he's going to be on my back forever. Emotional reasoning, which is confusing feelings with facts. I feel so anxious. Air travel must be dangerous. Labeling, which is using unhelpful labels to describe self, like I'm so horrible. Okay. Magnification, which is blowing things out of proportion. I forgot to buy milk, but my husband is going to be so angry with me. Okay. Communication tip. One way of explaining the process of cognitive behavioral therapy to patients is that it aims to help them notice and change mental bad habits, which we all have to a greater or lesser degree. The process of therapy draws on the principle that automatic thoughts and dysfunctional assumptions may be challenged or changed. And that would be by, for example, behavioral experiments, which is testing dysfunctional thoughts against reality. Using an example, we have a figure that illustrates the relationship between thoughts, feelings, and behaviors, how automatic thoughts and dysfunctional assumptions may affect this relationship, and how challenging these may result in change. Let's go there. Let's just, okay. We have situation like sitting an exam, and the thoughts about this would be something like, I'm going to fail, if I don't pass, I'm completely useless. These are the thoughts, These thoughts would make you feel anxious and unable to concentrate. And of course, physically, there would be some physical symptoms like stomach churning, trembling hands, and the behavior would be underperformance. And all of these things would affect each other. Okay. With cognitive behavioral therapy to help challenge irrational and unhelpful automatic thoughts and dysfunctional assumptions, these thoughts we would change the thoughts to be something like, I'm going to try my best. If I fail, it's not the end of the world. So these are new thoughts, more balanced thoughts after cognitive behavioral therapy. The feelings would be confidence and less anxiety, and no physical symptoms, and the behavior would be performing well. Okay. That was a good example, actually. Okay. CBT differs from psychodynamic psychotherapy in that it is time limited, 12 to 24 sessions. Okay. And it is goal oriented and predominantly focused on present problems, less concerned with the details of how problems developed or unconscious factors. The therapeutic relationship is strongly collaborative, deciding together on the session's agenda and case formulation. It involves patient doing homework as assignments. Also, due to its structured format, CBT is more amenable to efficacy studies. Some other forms of therapy that incorporate elements of CBT are summarized in the table. طيب. Okay, these are some therapists, some therapies that derived from cognitive behavioral therapy and psychodynamic therapy. We have, for example, EMDR, eye movement desensitization and reprocessing. The description of that is, at the same time as giving attention to difficult, usually traumatic memories, the therapist encourages the patient to attend to another sensory stimulus like lights or beeps. Eye movement are no longer thought necessary to the therapy. Rather, the gradual exposure to the memory in a relaxed environment seems important. Another kind is mentalization-based therapy. It is developed from psychodynamic therapy. This form of therapy focuses on allowing patients to better understand what is going on both in their own mind and in the minds of others. It can utilize both individual and group components. It can involve asking, how does my outside appears to other people's insides? Cognitive analytic therapy. Cognitive analytic therapy aims to help the patient understand the problematic roles that they repeatedly find themselves and others in, and the dysfunctional ways they cope with this. The aim is to increase the patient's flexibility in ways of relating and to find exits from dysfunctional pattern. The focus is on helping with present circumstances while understanding from the past how things have arisen. Mindfulness-based cognitive therapy, this is different from mentalization, but it is about mindfulness, okay? Utilizes traditional CBT methods in conjunction with mindfulness and meditation. Mindfulness focuses on becoming aware of thoughts and feelings and accepting them rather than reacting to them. So this is a quick review about CBT. Let's talk about IPT, Interpersonal Therapy. Interpersonal therapy is based on the assumption that problems with interpersonal relationships and social functioning are significant contributors to the development of mental illnesses, as well as being a consequence of mental illness. Okay. So, interpersonal therapy attempts to enable patients to evaluate their social interactions and improve their interpersonal skills in all social roles, from close family and friendship to community and work-related roles. One of the following areas is chosen as the main focus: role disputes, role transitions, interpersonal deficits, and loss of grief. Again, these are the main areas, Role disputes, let's just separate them. Role disputes, role situations, interpersonal deficits, and loss or grief. Interpersonal therapy tends to focus on current problems and is brief in duration. It's from 12 to 16 sessions. This is interpersonal therapy in brief, of course. What about dialectical behavioral therapy? Dialectical behavioral therapy uses combination of cognitive and behavioral therapies with some relaxation techniques and mindfulness skills. It generally lasts for 2 years with participants attending one individual and one group therapy session each week. Clear will boundaries treatment contract are drawn up regarding missing sessions and self-harming. Patients need to be stabilized, not recently in crisis, before embarking on the treatment course. DBT can be helpful in reducing self-harm and improving functioning in individuals with emotionally unstable personality disorders like borderline personality. What about motivational interviewing? Motivational interviewing is commonly used to help people with substance dependence, but it can be applied to help anyone change their behavior. That's the point, actually. So, motivational interviewing aims to strengthen the patient's own motivation and desire to change, making progress along the stages of change model. We'll talk about the model or the stages of change when we talk about substance use and such. Motivational interviewing avoids being directive, telling the patient what to do, as that can provoke the opposite reaction in someone who is ambivalent. Instead, the counselor makes a curious and collaborative stance, allowing the patient to voice in their own words what their reasons for change might be, what the first steps should be, and what they can do to overcome barriers to change. Key skills are asking open questions, practicing reflective listening, and summarizing. What about group therapy? Group therapy may be practiced according to different theoretical orientations, from supportive to cognitive behavior to psychodynamics approaches. Most groups meet once weekly for an hour and consistent of 1 or 2 therapists and about 5 to 10 patients. Therapy can run from months, CBT orientation, to years with psychodynamic orientation. Group therapy allows patient and therapists the opportunity to observe and analyze their psychological and behavioral responses to other members of the group in safe social setting. It is thought that group therapy owes its effectiveness to a number of curative factors. 10 curative factors, like universality, which describes the process of patients' realization that they are not alone in having particular problems. I think what's the name of that person that was talking about this? Yalom, Dr. Yalom. Anyways, that's general about group therapy. Family therapy, instead of focusing on the individual patient, this form of therapy treats the family as a whole. It may include just patients and siblings, or may also include extended family. It is hoped that improved family communication and conflict resolution will result in an improvement in the patient's symptoms. Similar group therapy, there are many different orientations, most notably the psychodynamic, structural, and systemic approach. What about therapeutic community? Milieu therapy. Therapeutic communities are cohesive residential communities that consist of a group of about 30 patients who are resident for between 9 to 18 months. During this time, residents are encouraged to take responsibility for themselves and others. by allowing them to be involved in running the unit. These communities may be useful for patients with personality disorders, especially borderline personality disorder, and behavioral problems. Hints and tips. Mindfulness is an increasingly common component of a range of psychological therapies. It is also something that many people in the general population choose to explore. In essence, mindfulness is keeping one's attention on the present moment. While trying to do this, it is common for a lot of thoughts and feelings unrelated to the present moment to come into consciousness. Mindfulness aims to non-judgmentally acknowledge these without shifting attention onto them. Okay. What about indications for psychological therapies? The psychological treatment options for specific conditions have been discussed in each of the relevant chapters on these conditions. We'll talk about them chapter by chapter. The main treatment options with the strongest evidence based along the relevant cross-reference are summarized here in this table. Let's talk about them. Here we have psychiatric conditions and the main psychological treatments used for them. For stressful life events, illnesses, or bereavement, we use counseling or supportive therapy. In depression, we use cognitive behavioral therapy. This is first, cognitive behavioral therapy, mindfulness-based cognitive therapy, interpersonal therapy, psychodynamic therapy, and group therapy. In anxiety disorders, we use cognitive behavioral therapy, mindfulness-based cognitive therapy, exposure and response prevention for obsessive compulsive disorder. They describe OCD within anxiety. Anyways. And systematic desensitization in phobias. For post-traumatic stress disorder, we use cognitive behavioral therapy and EMDR. In schizophrenia, we use cognitive behavioral therapy. We have a lot of details about that. We will not go through them right now. But yes, we use cognitive behavioral therapy. Of course, not in acute psychosis. And family therapy. In eating disorders, we use cognitive behavioral therapy, focused psychodynamic psychotherapy, interpersonal therapy, and family therapy. In emotionally unstable personality disorder, we use dialectical behavioral therapy, mentalization-based therapy, psychodynamic therapy, cognitive behavioral therapy, cognitive analytic therapy, and therapeutic communities. In alcohol dependence, we use cognitive behavioral therapy, group therapy, and motivational interviewing. You can see it obviously that cognitive behavioral therapy is there anywhere. Okay. Let's go to the summary. Chapter summary. Psychological therapies are first-line treatments for mild to moderate mood disorders, stress-related disorders, anxiety disorders, eating disorders, and personality disorders. The therapeutic relationship is more important than the modality of psychological treatment used. Self-help is often sufficient for milder problems. Counseling is unstructured, allowing the patient to generate their own solutions to problems. Psychodynamic psychotherapy aims to facilitate conscious recognition of unconscious processes causing problematic symptoms. Cognitive behavioral therapy aims to help the patient identify and change the links between how they think, feel, sense, and behave. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.